Thank you for inviting me to the organizing committee, and thank you for having me the chance to walk on this catwalk, because every surgeon has kind of a star heart inside, so we are happy to be feeling like the stars. This morning I would like to talk about should we advocate the live liver donation instead of the disease donor liver donation. I have no disclosures with this presentation, and no disclosure for Twitters or Instagrams. We know as the surgeons and the physicians, we see a lot of livers like that in our lifetime. The patients come with jaundice, ascites, ACCs, and gastrointestinal bleedings. So when you see the liver inside, it's very nice to change this liver with a beautiful liver, young, no fat, and less ischemic time. But to change this is our goal at the end. But the reality is not like this. We see the waiting list increases all the time. Even though we do more liver transplants, we have more deaths on the waiting list, and we see a lot of patients going to the waiting list because the results are good, and as the results are good, the patients want to have the liver transplants. So that's a limited resource and excessive demand. So the Titanic goes down, sinks. So what we do hard to increase the number of the cadaveric donors. We are working hard in our country since the last 20 years, but we only increase 2 points. We started with 2.7 points. Now the per million, the donation rate is 4.7. So it's not enough, because in the medical community, we have the conflict. Our mission as the healthcare professionals first, to minimize the death tolls, less traffic accidents, less strokes, less heart attacks. But as the result of this, we have less brain deaths. And on the other hand, there are a lot of people waiting for somebody to die and get the organs from them and to survive their normal life. So what can we do for this? We use marginal organs. Everywhere in the world we use this, and we continue using this with the new perfusion machines and so on and so. And we split the livers. We divided two to use for 2 patients, but it's still not enough. We forced to have some living donors, and these are forced by the doctors and the transplant programs, because we want to help the recipients. Also, we want to perform transplants for our professional gratification, and we all understand the goals of the transplantation. But we have to know that before utilization of the donors, they have to have a significant chance for the outcome of the recipient. So we cannot use all the living donors in a very, very bad patients that are about to die. So we have to make the definition of what is the success rate of the living donor. How much success? Because when you come to talk with the family says, even for 1%, we want to try this chance. Is it logical or is it rational for us? So we have to think about this. It should be low risk to the donor, and informed consent from the donor to take part in the process, so everybody should know about that. This story started in 1988 in Brazil and continued on Australia, Chicago, and the first right lobe after Tanaka's did in the kids, he said that this operation should never be done. But now we are doing nearly 2 or 3 a week in our center, and everywhere in the world they are doing more than a day. So in 1997, ST Fan and CM Lo in Hong Kong started doing the first adult-to-adult liver transplantation. And after that, it spread out to the world to use these organs. So why do we use these operations? Why do we do living donor liver transplantation? The idea is basically to cure the patient with end-stage liver disease. It's a unique option in countries where cadaveric transplantation is very low. And if you don't do enough liver transplants, you cannot establish a liver transplant center and a good liver transplant program. So you have to do at least, at a certain point, maybe the number is at least 80, but you have to have also excellent solution with pediatric patients. It's a very good chance for some ACCs, which I'm gonna talk about. And the most important thing, that you have a chance to save a life of a loved one. That's very important in live liver donation. It has a lot of advantages, but one of the most biggest advantages is this: recipient may have a greater sense of responsibility to care for the donated organs, because you take your organ from your brother, sister, wife, or son or daughter. So you have a responsibility to them, and you are under control of the family. So it might have a chance to make these organs survive longer and better. It has a lot of advantages for the donor also, to have a chance to save, as I told, the loved one. It's a heroic act, and it gives you a better position in the community and plus in the family. And it's an economical advantages for the family, because when somebody is sick in the family, you have strong boundaries in our country, so you go all together to the hospital. Not the patient doesn't work, all the family doesn't work. So if somebody gets well, the family goes back to their normal lifespan. So it is a very economical advantage. And there's one more advantage for the donors in Turkey. They don't go to the military service if they are not done their military services yet. So if you be a liver donor, you don't go to military service. So it's an advantage for some people too. For the recipient, it's a lot of advantages. There's no waiting time, no waiting list deaths. That has a lot of chances for the ACC because you are not going to wait. And for metabolic disease, you have a chance to have the operation. It's advantages for the doctors too. It's an elective operation. You go in the morning at 8 o'clock, you drink your coffee, start the operation, and finish by 5 o'clock and go back to your home. So you don't have to worry about your birthdays, the graduation of your son or so. So it's a elective and programmed operation. So you use better quality of organs. There is no chance for primary non-function, and you increase the size of the donor pool. There will be always people on the waiting list, so they're going to continue on waiting, but you have more donors in your hands, so you can do more operations. There are disadvantages. Basically, the biggest disadvantage is the responsibility of a healthy one. If you are operating a totally healthy person, and if something happens to that guy, you cannot sleep for ages. So it's a very difficult situation to take the responsibility of a healthy one. The other things that you need a bigger team. It's more technically demanding than the diseased organ transplantation. You can have a small for size problems. You can have more vascular problems. You can have a higher cost, and you have to be very carefully in legislation to prevent organ trafficking. So if you ask a patient which one you prefer, DCD donor, 60% fatty liver, long cold ischemic time, past tumor history, even brain tumor history, older donor, multiple cardiac arrest, and so on, or a donor from a liver, half of the liver from your brother, sister, or young son. So most of them prefer the living one. And in Turkey, we have to ask the recipients when we have a patient when we have a diseased organ that's retrieved from a brain tumor patient, then we say that, do you want this liver? And the answer is 99% no. They say that we can solve in our family. So that's a good chance for them, actually. But the liver transplant need in Turkey is like 2,000 a year. But we do only 300 from the diseased donor. So there's a big gap. We fill this gap with living donors. So as you see in Turkey, we started living donor transplants in 1996. It's more than 17 years now. And now in 2010, the government act helped us to improve the organ donation. Working hard, you see the blue lines are the diseased donors and the red lines are the live donors. So we do more than 1,000 live donors a year now in our country. It's more than all Europe per year. And it's one of the 4 big countries in the world, like China, Korea, South Korea, India, and Turkey. We are leading the world in the number of living donor liver transplantations. And the number of transplant centers are increasing every day, and now it's number 1 in this list. So per million, we have like 0.55 liver transplant centers. It's increasing every day because everybody wants to do liver transplant because we have a lot of a big pool for organs. And what's our experience? We started doing liver transplant in 1994. In 1999, we started living donors. And so far, we've done more than 1,000 living donor liver transplants. The government act started in 2010, basically, with Regional Ethical Committee, and it's free for all Turkish citizens. You can have your transplant everywhere in the country, in the university hospital, in a private hospital, in a government hospital, and you don't pay anything for that. We don't do unrelated for the foreigners, and we don't do disease donors for the foreigners. You have to be relative up to 4th degree, so you have a big pool from your side or from your spouse's side. So you know liver is a paired organ. It's like eyes, like lungs, like kidneys. So you can use one side safely if you are very careful in technique and you know the anatomy very well. So we can use any part of the liver. As you can see, the right lobe, left lateral with the caudate, left lobe with caudate, posterior right, extended right. So you can use every part of the liver depending on the patient and the donor status. And this kind of softwares help us to understand the anatomy better. But we have to know that donor risk increases as much the liver we get from the donor. The bigger the liver we get from the donor, the more risk we put to the donor. So is it superior or inferior? There are inferiorities and there are superiorities of living donor and the diseased donor. It's superior in HCC excluding Milan. In many countries, like our country, the patient, if it's not in Milan criteria, cannot get in the waiting list. So if you have a 5.1 centimeter single tumor, you don't have a chance to get any organs. So it's also for feminine, for pediatric patients, low MELD or high MELD patients. So the inferiority is that if you don't have any members to donate. But this inferiority comes to be a superiority if somebody else uses their own donors so they can have a place in the waiting list. So looking at special diseases for like hepatocellular carcinoma, ASLD guidelines in 2010 that there is no recommendation can be done regarding extending the listing criteria beyond standard Milan criteria. So many countries use this. The Milan criteria is the standard criteria for disease donor listing. And people, surgeons, doctors, everybody is forcing this criteria. So what we came out to be, after Milan criteria, UCSF criteria, center-specific LDLT criteria, survival estimation diagram, and now there's a special gift for the patient. So what we do is, it's a minimal goal, at least 5 years survival should be 50%, and reference goal we have to reach with live donor transplantation for the patients exceeding Milan criteria, 75 to 80% survival. So if we can succeed this, then it's a very good option for the patient, and it's very rational for the community. So we have to do transplantation before the vascular invasion. And you can see this patient exceeding Milan criteria had a chance to have a liver transplantation from his mother when she was 9 years old. It was a family-bounded hepatitis B, and he's fine after 2 years after operation. Now it's been 15 years after this operation, and he's still alive and having a good life. And there's a super Milan criteria. If the tumor is less than 2 centimeters, less than 2 tumors, and AFP is less than 200, and no pre-transplant treatment, the success rates goes up to 92% for 10 years. There is no cancer, I believe, that's better than this result. So for this super Milan criteria, you cannot have a chance to get a disease organ. But if you have a living donor, this survival is excellent for this patient. So rational is that you don't have to wait. If you wait more than 2 months, less than 2 months, the success rate for patients in Milan criteria is 84%. But if you wait more than 5 months, even if you are in Milan criteria, the success rate goes in the 54%. So living donor makes this happen. So you have a better chance with the living donors. Coming to acute liver failure. In United States, 66% of the patients with acute liver failure had their graft in 3 days. But in Turkey, only 19% got their grafts in 3 days at that time, the same period. So that means 80% patients will die without a graft. That was a study from the Hong Kong group. They listed 50 patients for emergency liver transplants, and the ones who couldn't get any livers from family or the friends, only one survived with the chance of cadaveric liver transplantation. Otherwise versa, if the liver transplantation done from a living donors, only 2 of them died. So you have a chance to survive after acute liver failure. what were we discussing about this? Inferior outcomes have the top priority. Coercion. What are talking? We have less than 20% of reaching the organs. So there is no top priority. It doesn't mean anything for the patients in Turkey. Inferior outcomes. That's well proven that there is no inferior outcomes for the grafts using from a living donor or from deceased donor. Coercion. The good thing of the living donor, when you see the patient, even if it's not needing a liver, you start preparing your donor. So you have time. And if the patient goes well, you don't have to use this donor. But if the patient goes bad, goes for the transplant, your donor is in hand ready for that. So it might be even better option because you prevent unnecessary transplantations, which is very important in acute liver failure setting because by the way of the ICU, the number of recoveries are increasing every year. Now, spontaneous recovery in certain diseases raised up to 65% after acute liver failure. So we have a chance not to transplant these patients. But if you are dealing with diseased organ, when you have the organ in hand, you have to use it. So even it might be a better choice than disease organ transplantation. Is MELD score important? This is the patient, the sample with a 13 MELD will never be listed in our country, which should be at least 15, and will never have a chance to get an organ. Here, he is debilitated, you see, with the cachexia and everything. And he had a liver transplant from a living donor. And we studied with the high MELD score. If the patient has a high MELD score and treated before the transplant, treated the infection, better albumin levels, treated the creatinine level, lower down the MELD score, so the outcome is as good as the low MELD score. So 1 year survival in low MELD versus high MELD responder, even they respond 1 point from 24 to 23, the results are better and as good as the low MELD score patients. So the living donor gives you a chance to treat the patients before the operation and get in a very good position. So it's the real advantage of living donor liver transplantation. And that's how the journey is started. The pediatric transplantation is the key point of this journey. So here you see a patient that we have operated 15 years ago when he was only 1.5 years old. Now he's a grown-up boy. So that's the story. That's the urea cyclase deficiency twins. One got a liver from his mother and one got a liver from his father. So basically they have no chance without any neurologic handicaps before the operation. So the pediatric transplantation is basically done in Turkey from the living donors and increasing every year, even though the disease donor rates are coming a little bit down. So I would like to say disease organ donation is a donation of life. It's anonymous. You donate for life. But living donor donation is a gift of life. You give a gift to your beloved one. So it's very important to know that. But for being sure, donor safety is very important. We are discussing from till the morning how safe is a living donor, being a living donor. There are deaths in the world. You cannot deny it. We know that at a point, if you do a lot of transplant, there can be a death. So the problem is not if, it's maybe when. So we have to know it. The problem is we don't have much idea how much donor in the world is dead and how they died, so we don't have any lessons from them. The centers don't tell it, don't write it, and the government don't write it. So we have to be, as a community, working together to know the outcomes of these donor deaths. As a donor, as a recipient, they are selfish. So we have to think for the donor also. And we made a study, if we really think about that. Looking at our study we have done for 70 patients that we have done 1 year before, the donor age is between 15 to 30. Gender is basically male. They are all adult patients, adult donors. They are mostly first-degree relative. Only unrelated is 1%, which is very, very low. The graft type is basically right lobe. And the recipients are 86% good, healthy. 8% is healthy but coming and going to the hospital. Only 5% died after the operation, after first year of the operation. So the question was it your own decision to become a donor? And the answer was 98% yes. And did you have any regrets after the donation? 93% say, no, I have no regrets. And how did the relation change with the recipient? Mostly better or the same. And what do you think about live donation? I think this is important because when you talk with the family about live donation, then the problem starts coming up. Because you put, if they donate, it's a problem maybe. If they don't donate, it's a problem. So the family must be aware of this treatment for 100%. All the donors said about that. So they are happy to donate their liver. And the question, would you be a donor again? And 83% said yes. 13% said for the family members, yes. And only 4% say, I don't know. They even didn't say no. They said, I don't know. So lessons from the survey that the outcome of the recipient is very good inspiration for the donors. So if the patients don't die, the outcome's good, the willingness increases. So the willingness of the operation, the donor is very important for these operations. And I think as the community and the doctors, physicians, surgeons, we have to tell everything in details, the options, pros and cons of the living donor and the deceased donor before making them their decision. And we don't have to forget that it's their decision, not ours. And I would like to say that this is like playing a big orchestra. If one plays bad, the living donor operation goes really bad. So I would like to thank all my team while working in this patients and donors, and I would like to thank you all for listening.